Hello, everyone. My name is Jordan.
And I'm Amber.
And this is our integrative partner review on aspirin versus beta blockers in preventing atrial fibrillation in post-coronary artery bypass graft patients. So looking at the overview and background, according to Carhusen et al., postoperative atrial fibrillation occurs in about 33% of patients who undergo a coronary artery bypass graft, also known as a CABG. This is a significant number, and many things are done in order to try and prevent the development of post-op AFib. One thing that is commonly done is prophylactic medications prior to the scheduled surgery. According to Butt et al., common medications include beta blockers, amiodarone, calcium channel blockers, aspirin, or a combination of all of these.
So during this semester, I created an integrative review that looked at the efficacy of beta blockers in preventing postoperative atrial fibrillation, while Jordan looked at comparing the effectiveness of 81 milligram and 325 milligram aspirin in preventing postoperative embolisms in CABG patients. So our combined PICO question is, for post-CABG patients, what is the difference in prevalence of new onset atrial fibrillation in patients administered pre-surgical aspirin compared to pre-surgical beta blockers 24 hours after surgery?
So looking at the significance, preventing post-op AFib is a clinical issue that has a lot of significance. The development of atrial fibrillation can greatly lengthen the patient's cost, patient's stay, and their complications. According to Khan et al., post-op AFib from a CABG creates about $10,000 of an increase in the cost per patient, with the annual cost amounting to about $2 billion. It also increases their stay by 4 to 5 days, increases their stroke prevalence, and increases in-hospital and long-term mortality. Two prevalent medications that are used in the treatment plan for CABG patients include aspirin and beta blockers. The reason for this integrative review to answer our PICO question was to see if aspirin played a role in preventing AFib post-CABG, or if it was just to prevent the complications that came with AFib, and to see if and why beta blockers are so controversial. It also was to see which medication played a larger role in preventing post-op CABG, atrial fibrillation, a very common post-op issue.
So our search methods included 4 different databases, and keywords that were searched were a combination of coronary artery bypass graft, atrial fibrillation, aspirin, prophylactic, postoperative, 81 and 325 milligram, preoperative, embolism, CABG, and beta blocker. 2 or 3 of these words were used at a time, such as CABG and beta blocker and aspirin. Another search was for atrial fibrillation and coronary artery bypass graft. These searches yielded a total of 23 articles. The articles were then reviewed to make sure that they included beta blockers or aspirin and atrial fibrillation. A total of 8 articles were selected for this integrative review.
All right, so looking at the different things that we had looked at, I had looked at 4 articles, and Amber had also looked at 4 articles that we closely reviewed. My first one was by Butt et al., which was a cohort study that looked at patients with new onset postoperative atrial fibrillation after an isolated CABG, along with their stroke prophylaxis and long-term risk of thromboemboli compared to non-valvular atrial fibrillation patients. It was found that the risk of thromboemboli was the same for both the postoperative atrial fibrillation patients and the non-valvular postoperative atrial fibrillation group after anticoagulation therapy. Huang et al. Was a systematic meta-analysis that looked at the effects of aspirin from a preoperative standpoint rather than postoperatively. They found that aspirin increased bleeding, but not to a point where a second surgery was needed. The risks of MI and mortality were not decreased in patients with aspirin preoperatively compared to postoperatively. Ho et al. Was a systematic review that looked to define incidence and the risk factors of DVTs, PEs, and to see if venous thromboemboli prophylaxis was effective in decreasing thromboemboli without issues post-CABG. they found that with high-dose aspirin and warfarin, there was no difference. The last one that I looked at was Verma et al., which was a meta-analysis that looked at dual antiplatelet therapy and if it was effective after CABG procedures. It was found that neither dual antiplatelet therapy or single antiplatelet therapy or high intensity versus low intensity dual antiplatelet therapy, neither of them decreased the risk of MI or stroke. They did conclude that higher intensity dual antiplatelet therapy compared to the low antiplatelet therapy did decrease mortality in post-CABG patients by about 50%.
The first article that I looked at by Wang et al. Was a meta-analysis conducted to investigate the short-term effects of preoperative beta blocker use for patients undergoing isolated CABGs. The experimental group were given beta blockers prior to the procedure and the control group were not. The study found that the experimental group actually had an increased incidence of atrial fibrillation compared to the control group. I then looked at a pilot study that was conducted by Abdul Salam et al., and it was to compare the efficacy of perioperative ivabradine, bisoprolol, or the combination of both for the prevention of post-op AFib at the patient's 30-day follow-up. The study showed that the combination of the two drugs was more effective in reducing post-op atrial fibrillation than either drug alone. I then looked at a meta-analysis by Thien et al., which was conducted to determine the efficacy of prophylactic rate control agents, in this case 3 different beta blockers, in reducing the incidence of post-op AFib in those undergoing elective cardiac surgery. The participants were given either sotalol, atenolol, metoprolol, or a placebo. The study found that the incidence of new onset post-op AFib was significantly reduced by the administration of prophylactic beta blockers compared to the placebo. I then looked at a meta-analysis of RCTs done by Xena, and it was conducted to provide a summary that compared oral beta blockers in terms of efficacy and acceptability in the prevention of post-op AFib. So the patients in the experimental groups were given 1 beta blocker, either atenolol, beta-xylol, carvedilol, metoprolol, propranolol, or sotalol, and the control group were given a placebo, and they determined that carvedilol was found to be the safest and most effective.
All right, so looking at the results, from the integrative review that I did, it was deemed that there was still a need for more research. It was not exclusively stated whether or not aspirin had any effect on post-CABG atrial fibrillation. However, it was found that it did decrease the risk of postoperative AFib related to thromboemboli. There also was not a lot of data on 81 milligrams compared to 325 milligrams, so that would be something that would need more research as well. While premedicating with aspirin before surgery caused for a higher risk of bleeding, that risk outweighed the benefit of decreasing those thromboemboli. For the integrative review that Amber did, it was also deemed that there was still a need for more research. Between the 2 articles that directly compared beta blockers to a control, their findings were inconclusive. One stated that beta blockers showed an increased risk of developing postoperative AFib, while the other said there was a decrease in risk. One study showed that if beta blockers are used, that carvedilol was shown to be the safest to use.
So when working to answer this PICO question, we came across a couple articles that were out of date, but we thought it would be worth giving them a read since they directly correlated to our question. When looking at the results of the 2 studies that looked directly at aspirin and beta blockers and their part in preventing post-CABG AFib, a study done by Phelan et al. Found that the use of cardiac medical therapy is understudied in CABG patients. This systematic review found conflicting evidence regarding pre- and post-op use of beta blockers. Many of the studies suggested that the use of beta blockers decreased AFib and decreased in-hospital 30-day mortality rates, but it was not consistent across all studies. When looking at aspirin, there was no significant data between aspirin and atrial fibrillation. While pre-op aspirin did decrease in-hospital mortality, if given 7 days before a CABG. There were conflicting ideas between time periods and how many days constituted being on aspirin before surgery. Some stated 7 days prior and some stated 48 hours prior. These differences can play a large role in why there's conflicting data.
And a study done by Khan et al., which was a retrospective chart analysis that also found that preoperative beta blockers did not decrease AFib. It also deemed that predictors like age, use of perioperative aspirin, and previous history of AFib were strong ways to determine if a post-CABG patient was likely to experience post-operative atrial fibrillation. The study suggested to keep using perioperative aspirin due to the benefits and protection against atrial fibrillation. However, it still needs to be studied in a larger setting.
So for our conclusion, we determined that there is still a great need for research in this area in order to answer our PICO question, as we found significant gaps in the evidence that we examined. But some strengths include that there is a recognition that more studies are needed. A lot of the studies that we looked at stated this, that they aren't able to come to definitive answers because there is a need for more studies. A lot of the articles that we looked at had really good inclusion criteria, and they specifically stated who they were including and why it was important. And many of the studies were conducted with a large sample size, which can help reduce the chance of type 2 error.
We also came across a number of weaknesses during this integrated review. One of those weaknesses was that the two articles that we found most relevant to answer our PICO question directly, which were the studies done by Fillion et al. And Khan et al., which were from 2007 and 2013, respectively. We knew that these articles were older than we preferred, but we included them to show that although there is some research already out there for this topic, there is still some more need for research. Another weakness is that atrial fibrillation episodes could have been missed if leads were removed from the telemetry box for any reason. Another weakness is that not every study used or explicitly stated the dosages that they were using for either aspirin or beta blockers. Some studies, when comparing them side by side, had different dosages, so it was difficult to compare their effectiveness. And the last weakness that we found was not every CABG procedure is done the same. There are different techniques that different surgeons use, and since techniques evolve over time, older articles for systematic reviews may show different atrial fibrillation results than some of the newer articles. All right, and these are our references that we had used. And that concludes our integrated review. If you guys have any questions, feel free to go ahead and ask those.